I invite Dr. Srikanth Sahasrabudhe sir for sharing his views on management of hypoxemic respiratory failure. The topic of his talk is, should I early intubate or give trial of NIV in hypoxemic respiratory failure? Sir is head Department of Pulmonology and Critical Care Medicine. He's senior consultant pulmonologist and intensivist at Medicover Hospital Aurangabad. His area of expertise is sepsis, mechanical ventilation, ARDS, COVID critical care. Welcome, sir.
Good afternoon all. Thank you madam for those kind words. And coming to Gujarat and being with my very close friends, it is always nice to spend quality time with Ritesh, Manoj, Ankur, Jigar, Gopal and so many. It's like an extended family. And even Dr. Ravi Raj who is sitting here, so we have kind of spent very nice time. And actually this was a kind of a debate topic, and since my opponent declared the he undoubtedly he just kind of took his status back. I am in front of you talking on both the topics, and I would like to kind of just give you some glimpses of what the literature is and what can we do at the bedside, and we'll embark upon early intubation versus NIV in coming about 20-25 minutes. So the famous quote of this great gentleman and this haunts not only for this topic but for majority of our intensive care issues which we face day in and out, be it IV fluids, mechanical ventilation, sepsis, shock, treatment of infection and so on and so forth. So I am also in the same position today, and we would like to kind of deliberate on both the sides, giving a practical and evidence-based take-home message. I would like to congratulate my colleagues and friends for such an innovative ideas, and every day we used to see flyers with such posters. I thought it is, it's a bit of revision when we see Bahubalis and Munna Bhai and my very good friend Manoj, where we will be talking on a very important and sensitive topic in the afternoon, and of course Abhishek, whom I troubled a lot. So having said that, I think what we are kind of as an intensivist or chest physician get exposed to acute hypoxemic respiratory failure, which is a very common entity across the board. And our non-intensivist friends always tease us and kind of criticize us that intensivist, if they see an X-ray and if they don't understand anything, then according to them the diagnosis is ARDS. So now even an orthopedic surgeon, a general surgeon, a psychiatrist also started reading the X-ray, "Arey, ye to sir ARDS lag raha hai." So it may not be true, where we core intensivists know that that is not the case. So it's a very simple, plausible explanation and approach towards ARDS is we obviously treat the cause and give them some oxygen if they are hypoxic. Of course, there's a huge role of HFNC, especially in the COVID pandemic, and because we had a completely separate gamut of pathophysiology which we were exposed to in the last 2.5 years. But here we are probably mainly focusing on the non-invasive and the early intubation. Now let me start with this systemic review and a meta-analysis, which is a decently recent 2020 JAMA, which was published in JAMA with Association of Non-Invasive Oxygenation Strategies with all-cause mortality in adults with AHRF. And this was a meta-analysis, so there were 25 RCTs with only one RCT which did not have actually intubations in that particular trial. There were about 4,000 or 3,800 patients, and as I said, they actually compared non-invasive versus HFNC versus standard oxygenation, and those who got eventually intubated and invasively mechanically ventilated. So the objective of this particular study was to find an association of non-invasive oxygenation strategies with the mortality and the endotracheal intubation in adults. So what did they see? That clearly the helmet non-invasive ventilation, of course, again this came in vogue especially after the COVID pandemic. Earlier, uh, personally I felt that I was not exposed to helmet non-invasive ventilator before the COVID, but here in this particular meta-analysis, it was clear that the helmet non-invasive, the standard mask non-invasive, and the HFNC clearly stood apart from the they stood apart, and they showed that there was a lower risk of uh, invasive or endotracheal intubation in the patients along with the mortality. So obviously they stood uh, above the other strategies in terms of ventilating these sick acute hypoxemic respiratory failure patients. So this message is that yes, this has started showing some signals towards the non-invasive mechanical ventilator strategies, especially in the form of helmet ventilators. If you read the meta-analysis, they clearly show inclination towards helmet ventilators. Now, I thought I will just quote this particular Florali, very famous Florali trial which came in NEJM in 2015, and these were the two countries, France and Belgium, the ICUs from these two countries, about 23 ICUs and 300 odd patients, where the PF ratio in acute hypoxemic respiratory failures were less than 300, and it was mainly probably focusing on HFNC as a therapy, where I would like you to kind of see this, where in NIV group there were about 50% of patients who got intubated eventually, and 38% who got intubated were the patients who were on HFNC. So this trial showed that okay, fine, HFNC could be little better than non-invasive ventilator in terms of possibility of the patients going eventually on a invasive mechanical ventilation. So if there are any students, and this is a very favorite questions in exams, and we always like to summarize and revise few things. So these are the class 1 recommendations for NIV as of now: reducing the need for intubation and mortality, especially in type 2 respiratory failures, that is COPD, and acute cardiogenic pulmonary edema. They are the very standard two indications, and there were a few question marks about the non-cardiogenic or any other non-cardiac causes of pulmonary edema, including the ARDS. So there was a little question mark on that. Having spent about 20 years in intensive care medicine, it's still a very short time, but it's reasonably long enough to stand on the podium and say something. So I think that it is more of an art, not only for ventilating patients or selecting an antibiotic or having interpersonal relationships and so many other things. I think it is more of an art, and we should know how we can put out the art out of us and put at the side of the science. Commerce, of course, the hospital management will think about the commerce, but then yes, it is an art, and myself, who is extremely fond of this particular instrument, we try to find out a balance between how can we deliver or institute a therapy where we have a perfect recipe, and there is nothing called as a perfect recipe for anything, but with a proper ingredients and a case to case or a individualized approach, where you take into consideration the patient selection, the interface, ventilator, the mode of the ventilator, and the methodology. So you're talking in terms of non-invasive ventilator, these are the important things. And there are many RCTs which have shown that in selective centers with a high experience of NIV, which cannot be actually translated into the real world. So there are so many other, multifaceted reasons where the NIV may not actually really work for any patient. Having said that, after COVID, you know, almost each and every doctor on this earth is aware of NIV, HFNC, intubations, score, not not the cricket match score, but the CT score, and so on and so forth. So there are many things which are, they're loaded with the information which may not be used in a proper sense. So the skill is important, the standardization of the protocols are important, and the expertise is certainly important. I thought I should mention about this particular very very recent paper which came out in BMJ, and it's probably one of its own, which talks about non-invasive ventilator for acute hypoxemic respiratory failure, and it actually aims to see the effect of NIV on ventilator-free days in patients with AHRF. So it's a retrospective analysis spanning about 9 years and compared NIV versus early intubation. Now the definition of this early intubation is again you cannot find any definition of early intubation. It is quite subjective, and it is just to kind of compare the two things where which particular strategy is useful. The primary outcome was ventilator free days, and the secondary outcomes were ICU and the hospital length of stay and in hospital mortality. So what did they conclude? Compared with the early intubation, NIV use was associated with more ventilator free days. Having said that, it did not translate into the shorter hospital length of stay or ICU length of stay. So this was a single center. That was a drawback of this particular study, and this is the same thing. So basically it is they have quoted this, that this is one of the first study which compared the outcome between these two treatment modalities, and you could see that the ventilator free days were obviously more with NIV. 65% of the patients on NIV eventually required intubation, so they were called as NIV failures. And the lung safe study, which was earlier done to this, which showed the low NIV failure as compared to this particular present study, and which obviously mounted to high mortality. So this was another very good kind of a snapshot which I took from the European Respiratory Review, again which talks about the timelines, different timelines as far as the use of NIV into this particular intervention is concerned, in terms of risk of ARF, where NIV can be as a palliation, ARF at the risk of getting invasively ventilated, where NIV can be used as a sealing or again a palliation, and ARF at the risk of death, where you can actually use as a alternative to invasive ventilation or weaning from mechanical ventilation. So as we know, is a very standard teaching that non-invasive ventilator, you take out the tube and put the patient on non-invasive, but this happens and this works well in type 2 respiratory failures and not in type 1 respiratory failure. So talking about the type 1 respiratory failure or hypoxemic respiratory failure, the cardiogenic pulmonary edema, where there are so many data and the literature which is going on for the last 30 years as far as the role of NIV in this particular clinical entity is concerned, where it decreases the preload and the work of breathing. It recruits the alveoli, therein improving the oxygenation, and the guidelines, mainly the ERS and the ATS guideline, which actually have put there in the recommendation, where it decreases the mortality and the need for intubation. So again, this is just for the sake of having some evidence to you, where you should be comfortable and confident enough from today onwards to put the patients on acute cardiogenic pulmonary edema to take care of the hypoxia. But the ACS, or the acute coronary syndromes with cardiogenic shock, there has been a little gray area as far as NIV in this particular patient category is concerned. And in another about 4 or 5 slides, I'll discuss the role of NIV as regards how did it fared in these particular patient categories in terms of whether how many patients or how many patients required intubations later on. So this is immunocompromised, which showed that they were having less intubations if you use them at a correct point in time and with mortality benefits. There are a few guidelines which support the use. The terminology is the de novo AHRF means that there is no chronic cardiopulmonary disease in the patient. So it's a de novo. NIV seem to be working on these particular patients with improvement in oxygenation, decrease in the dyspnea and the work of breathing, and it may actually avoid intubation. But the flip side of this is that it can cause de-recruitment, VILI, that is the ventilator induced lung injury, and the CILI, which has come out in the recent, again after the COVID, where it is a self-inflicted lung injury, especially with the high respiratory efforts and the high tidal volumes which the patient generates. It has also been shown to mask the signs and thereupon delaying in the intubation and again causing the mortality. So in ERS and ATS doesn't recommend NIV in de novo AHRF, and that is what the literature says. In post-operative surgical patients, where we very commonly see the patient comes out of the OT in the ICU and they're anesthetized, they have pain and the diaphragmatic dysfunction exists, which leads to the loss of respiratory muscle function, the volume and the atelectasis. So guideline definitely recommends NIV into this patients category, either BiPAP or a CPAP, which is again shown to avoid intubations and decrease the nosocomial infection rates, the LOS and the morbidity and the mortality. So these are, I thought it is a good idea to kind of throw upon a few clinical situations which we day in and out kind of get exposed to. Endoscopic procedures, there's a very small kind of data on this, but blunt chest trauma, yes, the underlying contusions, the lacerations, pneumothoraces or the flail chest, where the pain control is the mainstay. But again, there are a significant literature which supports NIV in few subset of blunt chest trauma patients, along with the other management, including the management of the flail chest or the pain control, where the NIV can be definitely useful and may prevent the need for intubation. In pandemic, there's, I can't say much because you all are aware of that, especially the H1N1 and the risk of the transmission of infection related to NIV. This is another very important aspect, especially when we talk about oncological patients or the chronic lung disease or end stage lung disease patients, especially the ILDs or the CHF and the advanced COPDs. There are definite kind of markers where you can actually put these patients on NIV, which will actually alleviate the respiratory distress, and these are few of the benefits. It will allow the communication of the patient and provide the time for the final decision if you are instituting the NIV as palliation, and it will give time to accept the death of the patient. Talking about the flip side is, of course, the patient will be in discomfort with, you may actually have a feeling of whether you are prolonging the dying process. Of course, there is a cost involved, and you cannot forget the complications of NIV thereupon. Now, in a nutshell, this is a kind of a flow chart which will give you a very good idea of how we can have the likelihood of NIV success. So on the left side, on your left side, you can see that the high, moderate and the low chances of the success of NIV. On the right side, you could see the stage of the ARF and the goals of NIPPV. So this is, I thought this was another very good kind of which will give an insight into how NIV and can help us in our ICU patients management. What are the causes of NIV failures? Because we are talking about early intubations, and obviously you need to actually see and monitor bedside on a very, very frequent basis to know why and how and really the NIV failure happens. So it would be obviously one is hypoxemic de novo ARF, and I quoted few references about the same. The PF ratios of less than 200, which is important, and it has been said that about 5 to 60% of the patients have this NIV failures, which depends upon the type and the severity of ARF, the expertise and the care provided. And it is in turn actually divided into immediate failure, the early failure and the late failure, depending on the time spans, and you could read for yourself. It is mainly, the thing is, again as I said, if you have a very, very clear cut absolute contraindications for non-invasive ventilators, plus minus, you could clearly see that the patient is not improved on non-invasive ventilator for 1-2 hours or maybe about 4-5 hours, please don't hesitate and go ahead and intubate this patient, because at the end of the day you want to save the patient. So these are the strategies and the integrated approach which one needs to find out as to how can we help the patient. And you could see, I think this is also another very, very good practical snapshot of at the bedside which we can offer. So for severe hypoxemic, we can take help of HFNC as a integrated approach. For the patients having burden of secretions, you can take help of this cough assist device, including the bronchoscopies if required. As far as intolerance and neurological dysregulations is concerned, the analgesic sedation approach can be useful, and the Willy, which will be taken care of by protective ventilation. So this is in short kind of summary as to how we can approach a patient who is hypoxic in front of you. So my takeaways, of course, I realize, and we had a talk when I was traveling with Manoj, that this is I think Mr. Kurian, who started his brainchild of Amul, and Amul Doodh Pita Hai India, although I could not drink it today, but but then yes, I'm very happy to be here. So remember that is the individualized approach with some kind of thought process on the etiology of the acute hypoxemic respiratory failure. And this particular statement is true for almost all the aspects of medical therapy in intensive care at present point in time. So it is more art than a science, and that we should learn. Rarely you will have a perfect recipe, and that is what I said. You need to actually find out and really put your head into the fact that why the NIV has failed, and strategies to mitigate the NIV failures along with the adjuncts and the integrated approach which I just now shared. And of course you need to go ahead and intubate the patients in this particular scenario. But when in doubt, my suggestion, I will probably err on early intubation at any point in time. If you have any doubt, please intubate this patient and don't let them die because of non-securation of the airway. Okay. So I really thank you all, and I thank my friends, all the organizing committee members for such a wonderful CME today. Thank you very much.
Thank you, sir. Any question? On a lighter note, patient asks, Doctor, how often patient die during the procedure? Doctor says just once.
So if you allow me to say
Sure.
again on a lighter note, that there was a garland which was kept inside the OT, and the patient was wheeled inside the theater, and the patient saw that garland and asked the doctor, why is this garland kept here? So he said, it is not for you, it is, if I get successful, it will be for me, if not, then it will be for you.